If you've been feeling overwhelmed about all the different types of tearing during childbirth and what that could mean for you, this video is going to be for you. Welcome to the Mama Stay Fit YouTube channel. I'm Roxanne, a certified nurse midwife and previous labor nurse of like 10 plus years. And we're going to be discussing all of the nuances of lacerations and vaginal tearing in this video. Vaginal tears during childbirth are very common, and the type varies person to person, and the statistic varies depending on where you're located within the world, but they say about 80 to 90% of people will have some sort of tear or trauma to the vagina during birth. And this doesn't mean that they're all severe tears or that they all require a repair, but there's some sort of tearing that is happening in that tissue and area during childbirth. So knowing this can give you some reassurance that if you did tear, it is the norm for most people, but the degree of the tear can vary depending on the person. And does everyone need to have a tear that they require then sutures? No, that part may not be as common in that 80 to 90%, but let's discuss it. But first, before we dive in, what even are vaginal lacerations? What does this mean? This means that within the vagina, so this is my little vagina, within this area, there is some sort of trauma that is causing bleeding that requires wound healing. Varying degrees from just maybe the first layer of skin to maybe now first layer into the muscle and maybe now into sphincters or more functional areas that require more in-depth tearing repair. Those are the different things that can happen within vaginal birth. Sometimes they're just what we call skid marks, where it's when you fall down and you just rub your knee on the ground. So it's just an abrasion that just requires a day or two of healing and then you're good as new. And sometimes it is deeper, where it does require sutures to bring the tissues back together and decrease the amount of bleeding that's occurring, as well as help improve the function of it, because some of these tears can involve sphincters, especially anal sphincters, so your rectum, that requires a lot of function, so we want to make sure those are repaired well. Most of the time when we're talking about vaginal lacerations, they're going to be talking about the perineum, which is from the opening of the vagina to the rectum. This little skin in between is known as the perineum, and these are the most common types of tears, as well as the one most people talk about. The other types of tears, though, there are in the vaginal structure. You can also tear there in the labia, the clitoris, the urethra, all of those areas as well, because the baby's still stretching those areas. But because the most commonly talked about is the perineum, I will spend a lot of time on those areas. And again, do all tears need to be repaired with sutures? No. Not all tears need to be repaired with sutures if they're not super deep and they're not bleeding. So sometimes a labial tear won't be bleeding and it can be more painful to have to repair it if you don't have an epidural. So sometimes you can leave those open. Sometimes even a first degree perineal tear, because it's just into that first layer of skin, if it's not bleeding heavily and it comes back together very nicely without us having to suture it, you can leave it unrepaired and allow the body to just heal it on its own. But when it's bleeding heavily or it's more severe or deeper, so a second or third or fourth degree tear, those ones would require some sutures, as well as maybe the labia if they're bleeding heavily. Those things would require some sutures. If you have an epidural, they'll leave your epidural running so that you have pain relief during that repair. But if you don't have an epidural, they'll use lidocaine, because just because you had an unmedicated birth doesn't mean you need to have an unmedicated repair. So the lidocaine will cause some numbing in that area. They'll allow it to set and numb, and then they'll do the sutures. With lidocaine, it doesn't take away all of pressure sensations sometimes, so you might feel tugging and pulling, but it shouldn't be painful. If you're feeling pain, let your provider know so that they can use more lidocaine, or potentially think about maybe not repairing that area if they can't get the pain under control. In some hospitals, if you do have a nitrous oxide option, they can use that to help with the repair as well if you did not have an epidural. So now what are the degrees of tears? There are 4 main degrees of perineal tears, and this would be from the vaginal opening to the rectum. So a first degree would just be into the first superficial layer of the skin. Like if you just gently cut your hand, paper cut, it bleeds a little bit, but it comes back together nicely, to maybe a little bit deeper than a paper cut. But it doesn't involve any muscles or anything. It's just really that superficial layer of skin. A second degree would be further now into that perineal muscles or pelvic floor muscles are involved in varying degrees. Sometimes it could be a very shallow second degree or a deeper second degree that may affect how long it might take to heal as well as your comfort while it's healing. But most of the time, first and second degrees are the most common, and they usually heal without any difficulties. The prevalence of someone having an intact perineum, which means they had no tears that require repair or anything, is about 10 to 20% of births. And this makes sense because if 80 to 90% of people are tearing, then 10 to 20% don't tear. But that is an intact perineum. If you have a first degree laceration, this occurs in about 5 to 15% of births. And then a second degree is actually the most common type of tear, and this occurs in 29 to 35% of births, which seems like a high number, but again, a second degree usually heals without much issue. When we get into the third and fourth degree tears, these are the more severe tears because of its involvement with that anal sphincter. So a third degree tear goes all the way through a first and a second into that anal sphincter, again in varying degrees. But the third degree, because it involves that anal sphincter, does require lots of rehab postpartum, so seeing a pelvic floor PT, and you want to make sure that it's repaired appropriately so that that sphincter involvement isn't being affected. This occurs in about 1 to 7% of births. Still not super common, but we would like to avoid it if possible. And then the fourth degree tear is where it goes from the vagina all the way through the sphincter into the rectum. And this occurs less than 1% of the time. A fourth degree tear is not super common, it's very rare, but when it does occur, it can lead to long-term complications with pelvic floor function as well as stool function. So it can lead to higher rates of stool incontinence or just constipation, lots of things. So addressing it and ensuring it's repaired appropriately and identified appropriately can be really beneficial for just healing in general. And with third and fourth degree tears, for sure, pelvic floor PT should be recommended postpartum or required to be referred postpartum. But a first and second degree can still also benefit from pelvic floor PT to help with the healing and ensure that it's healing appropriately. But other than those degrees, what are the other types of tears that you can have? Because this is often not talked about, and people are like, what? What do you mean I tore my labia? I didn't know that was possible. I've only ever heard of a first to a fourth degree. What is a labial tear? So we have our labia, which is our skin folds that go around our vagina. And this is being stretched. Your labia is being stretched as your baby is coming out. So you can tear into the labia. Sometimes it can be lateral or horizontal, whichever way, vertical. It's just depending on the way the baby came out that can tear. And we can repair it if it's needed. Labial tears are actually the second most common tear after any of these tears. So this occurs in 40 to 50% of births. And again, we can repair them and they usually heal without any complications. They can happen on both sides or one side sometimes. The next one that can occur is a periurethral. So this is your urethra where urine comes out. And this is also getting stretched and can have some tears, usually next to it. So periurethral is next to the urethra. And sometimes this can cause an issue because if they swell up, it can close off that urethra and decrease your ability to be able to pee. So sometimes we may need to either put a Foley catheter in there as well as potentially put in some stitches. A lot of the time we try to leave it alone and just let it heal on its own. But if that area does have some trauma, sometimes the Foley catheter will allow it to heal without overswelling and decreasing your ability to pee. Periurethral and clitoral tears, because the clitoris is directly above that urethra, those ones occur in about 15%. Clitoral tears are not very common. I think I've seen maybe 1 or 2 of them in my entire career. Most of the time they're that periurethra, so involving that urethral area more so than that clitoral area. The next common type is in the vaginal vault. So as the baby is exiting the body, they can tear along that vaginal canal, either deeper, closer to the cervix, or sometimes more commonly at the lower portion of the vagina at the opening. And this can occur like 60% of the time. There's some sort of tearing in there. Does it all need to be repaired? Not always. They usually will just heal on its own. But sometimes they do need to be repaired if they are bleeding heavily. So the deeper they are in the vaginal vault, sometimes known as like a sulcal tear, that can occur in like 14% of births. And those ones will bleed a lot and need some sort of repair and can lead to a postpartum hemorrhage if not addressed and identified early. But vaginal vault tears usually don't have as much bleeding and can be sutured and doesn't have as much risk associated with it. But you can still tear inside as well. And then speaking of inside, the other thing that can tear sometimes, although very, very rare, is the cervix. So if the cervix, a lot of the times, if it's not fully dilated, and you're like 5, 6, 7 centimeters and it's not just melting away, sometimes that cervix can tear in the process. And the cervix is very vascular. So this also could increase that risk of postpartum hemorrhage if that tears, because you can just bleed from the cervix. This occurs like less than 2%, like less than 0.2% of the time, but cervical lacerations, because of that increased risk of postpartum hemorrhage, are taken very seriously. And they would like you to not push on a cervix that is not fully dilated for that reason, because of the risk. But if you're pushing and you have a normal physiologic birth, this is a total tangent. If you have normal physiologic labor and you're feeling this strong, uncontrollable urge to bear down, listen to your body. Usually your cervix will melt away within a few contractions. If it does not, then we need to address it. Now, usually when we're talking about tearing, the next question is, how can I prevent myself from tearing? How can I be in that 10 to 20% of people with an intact perineum, or even just like a first degree laceration that doesn't require much healing? These are our tips of how to prevent tearing. And we have a whole video on tips to prevent tearing, as well as tips to heal if you do tear, because even if you tear, it's not your fault and we can heal from it. It may take longer depending on the degree of tear, but you can heal from it. But what are our tried and true tips on how to prevent tearing as much as possible? 1, have a provider that believes you do not have to tear. There are providers that believe everybody has a first or second degree tear despite everything that we do. And those providers may not try to do things to help you prevent tearing or decrease the severity of the tearing. So having a good provider, asking them like what is their management of pushing to see like how many of their patients tear, and those types of questions can be helpful to determine what is your provider's philosophy on tearing. The next is when we're crowning, to relax your legs. Your perineum has only so much stretching ability. So if we're pulling our legs all the way to our chest, stretching that perineum to its max stretching capacity, there's no way the perineum is going to be able to stretch more to be able to accommodate the baby's head. So it's going to have to tear. So by relaxing our legs, this is also decreasing the pull on the perineum to allow the perineum to have the ability to stretch around our baby's head and not tear, hopefully. Slowing down the pushes when the baby is also crowning. This is when instead of holding those 6 to 8 second pushes, you're only pushing for maybe 2 to 3 seconds to like slowly ease your baby's head out. And sometimes this may need to happen over a few contractions to fully allow it to stretch around the baby's head in hopes that it doesn't tear. Using different things like warm compresses. Some people will use mineral oil or olive oil to also help allow that tissue to stretch easier. But sometimes being hands-off can be beneficial. The research on using perineal massage during pushing and being hands-off is a little bit mixed. It does decrease the risks of episiotomies, but we are still deciding on if hands-off delivery is the best. Research-wise, I do believe that in practice it's individualized, because some people do benefit from a little bit of stretching with the perineum when they're pushing, but a lot of the time, if we just keep our hands out of there, we're also decreasing any trauma that we could be causing to that perineum. If you've had a baby before, this also just naturally decreases your risk of tearing. So if it's your first baby, this is the highest risk of tearing, and most of the time, first-time birthers are going to tear. more likely than someone who has had babies before because the perineum has not been stretched before. Whereas once you've had a baby before, your perineum has like muscle memory to be able to stretch and accommodate the baby's head and be less likely to tear. So while we would love to take credit for all of these things, if you've had a baby before, that is likely one of the reasons you maybe didn't tear with your subsequent babies. In perineal massage, this is the one that has also mixed evidence on if it actually is beneficial at decreasing your risk of tearing during childbirth. The evidence does support that it can decrease that risk of those 3rd and 4th degree tears, again, which is involving that anal sphincter. We don't want the anal sphincter or the rectum to be involved with tears if we can avoid it. So perineal massage in first-time birthers does decrease your risk, but it hasn't been shown to decrease the risk of 1st and 2nd degree tears, regardless of 1st or 2nd or 3rd babies, as much as those 3rd and 4th degree tears. But if you want to do perineal massage and you feel comfortable doing it, by all means, it's not beneficial maybe at creating the ability of the tissues to stretch per se, but it is creating this response in your brain where when you feel this stretching sensation that you're doing yourself, once your baby's head is doing that, you'll still be able to relax and breathe through it and decrease any tension you're holding, which could increase your risk of tearing in that perineal area. So just to recap, all of the different types of tears that you can have. You can have a vaginal tear, which is the vaginal canal, labial tears, periurethral, clitoral, and cervix, as well as the vaginal canal can be more superficial to the entrance or more deep sulcal tears that are usually bleeding a little bit heavier. With the perineum, there are 4 different degrees of tears. The 1st degree is just into that first layer of skin. The 2nd degree involves the pelvic floor muscles. 3rd degree involves the anal sphincter, but not all the way through. And then the 4th one, it has gone all the way through the sphincter into the rectum, and now the vagina and the rectum are one whole. The 3rd and 4th degree tears are the more severe tears and does require some pelvic floor PT as well as rehabilitation and more detailed repair of those areas to ensure function. But they are the least common of all of the tears, along with cervical tears. Things that you can do to decrease your risk of tearing is having a provider that believes that you don't have to tear. Relax your legs when crowning, as well as slowing down your breaths when crowning. Using warm compresses could be beneficial. Being hands-off, but person dependent, you may need a little bit of perineal hands-on massage during birth, but research is still mixed on perineal massage during pregnancy on if it would help with 1st or 2nd degree tears, but for sure 3rd and 4th degree tears are reduced when doing perineal massage in pregnancy. And if you've had a baby before vaginally, this also decreases your risk in subsequent births for tearing, so that is just one thing you got on your side if you're deciding to have more than one kid. Vaginal lacerations are something that a lot of people are very concerned about. So we do have more resources on how to prevent tearing. We have full videos that we'll link in the show notes below, as well as we also have videos of if you do tear. We have podcast episodes with the pelvic floor PT on how to heal after having a perineal tear or vaginal tear in general, what are tips to do immediately after birth as well as long term, and what are the things to look for that are signs to maybe seek help if you had a tear that maybe is not healing as optimally. And we'll link all of those things below so that you can have all of the resources, because tearing can be scary, but knowing that you have the tools available to either decrease your risk or to heal from it afterwards can help you take away that fear a little bit of tearing in childbirth. I myself did have a 2nd degree tear with my first baby and then a 1st degree tears that did not need repairs with my last 2. So there is a chance and there is hope that you may not have bad tears in your childbirth, as well as I've also supported many births, even first-time babies that had no tears in their perineum. So there is hope out there, and I do believe that 10 to 20% of intact perineums is closer to 20% personally, but every birth is unique and we're all individuals, so accept your birth outcome, hopefully, as it comes. If you're pregnant and looking for more support like this, check out our online childbirth education course where we discuss the science of birth to take away that mystery and fear surrounding it, because it is a natural process that occurs within our bodies that we can support in different ways. And we discuss all of the ways that you can support it, as well as if you're needing to be medically induced, we also include those options as well. Everything with interventions in birth, from epidural to induction, are tools available to us, and when we want you to feel confident if you need to use those tools during your birth. We also have a prenatal fitness program to help prepare your body for birth, not just for birth and being comfortable in pregnancy, but also postpartum recovery to make it a little bit easier. And you can check out all of our resources on our website at momstayfit.com. And as a thank you for listening to this entire video, you can use code STORY10 to get 10% off any of our offerings. And if you enjoyed this video, please be sure to like and subscribe to our channel so you can be notified whenever we release new videos. We release new fitness videos every Tuesday and more educational content on every Wednesdays. And if there's a topic that you're wanting us to create a video on, let us know in the comments below.